Welcome to the presentation Heart and Neck Vessels. I'm Lisa Pugsley, and this presentation is based on Chapter 21 of your text. The objectives of this presentation include discuss nursing concepts as they relate to the assessment of the cardiovascular system of the pediatric patient, the adult, the pregnant woman, and the elderly patient. Recall cardiac and neck vessel anatomy. We'll briefly go over cardiac and neck vessel anatomy, but we're not going to spend a lot of time on that because you've already had an anatomy and physiology class. Discuss risk factors of cardiovascular disease. Perform physical assessment of the heart and neck vessels using proper techniques of inspection, auscultation, and palpation. Describe specific considerations for the different populations. Analyze cardiovascular assessment findings in order to develop accurate nursing diagnoses regarding the cardiovascular system. The concepts of perfusion, assessment, culture, caring, patient-centered care, communication, and critical thinking will be woven throughout the presentation today. If you have questions about these, please don't hesitate to ask when you get to class. Before we get started on the assessment of the heart and neck vessels, we'll do a brief anatomical review. In order to assess the cardiovascular system, it's important to understand the cardiac landmarks. We'll start with the precordium. The precordium extends from the top of the sternum down to the xiphoid process. The next cardiac landmark is the apical area. So the apical area is at the apex of the heart. It's between the fifth and sixth ribs, which is the fifth intercostal space. And you measure the apical pulse there. You can palpate the apical pulse. You can also auscultate the apical pulse. The chambers of the heart include the right atrium, the right ventricle, the left atrium, and the left ventricle. It's important to note that the atria are the upper chambers of the heart and the ventricles are the lower chambers of the heart. The great vessels include the superior and inferior vena cava. These vessels bring blood from the body to the right atrium. The next is the pulmonary artery. The pulmonary artery takes blood from the right ventricle to the lungs. Then you have the pulmonary veins, which bring blood from the lungs back to the left atria. The next vessel is the aorta, and the aorta brings blood from, or takes blood from the left ventricle out to the rest of the body. And then there are arteries and veins that branch off all of these great vessels. Let's review the chambers and valves. So, like I said before, the right and left atrium are the upper chambers of the heart, and the right and left ventricles are the lower chambers of the heart. And I want to briefly go over blood flow through the heart because I think sometimes that helps you understand assessment when you can understand how the blood flows through the heart and the body. So we'll start with the body. So the blood is out in the body. It goes into the inferior and superior vena cava through all the branch veins. And then from there, the blood goes to the right atrium. And then after that, it goes through the atrioventricular valve or the tricuspid valve to the right ventricle, then out through the pulmonary artery to the lungs. So from the lungs, it goes from the pulmonary veins to the left atrium, and then from the left atrium through the mitral valve to the left ventricle. And then from the left ventricle, it goes through the aortic valve into the aorta out to the body. And there's a nice picture in your book on page 417 that goes over all of this anatomy. The electrocardiogram is a visual representation of the electrical impulses that go through the heart. So the P wave is the depolarization of the atria. The sinoatrial node sends electrical impulses through the atria down to the atrioventricular node, and this causes the contraction of the atria. The PR interval is the time between the beginning of the P wave to the beginning of the QRS complex. The QRS complex is when the atrioventricular node sends electrical impulses down through the Purkinje fibers through the ventricles. This causes the ventricles to contract. When you see the QRS complex, that is the electrical impulse that causes the ventricles to contract. Then the T wave is the repolarization of the ventricles. This is the time when the ventricles are at rest so that they can repolarize. It's important to note that the electrical impulse occurs slightly before the mechanical events of the cardiac cycle. Part of the assessment of the cardiovascular system is assessment of the neck vessels. So it's important to know the anatomy of the neck vessels. So the carotid arteries lie just lateral to the larynx, and then the internal and external jugular veins lie just lateral to the carotid arteries. Prior to obtaining objective data, it's important for the nurse to obtain subjective data of the heart and neck vessels. Subjective data includes history of present concern, and you want to use cold spot to investigate those symptoms. Some common concerns related to the cardiovascular system are tachycardia, palpitations, fatigue, dizziness, and edema. Remember, when you're asking questions regarding subjective data, to use plain language. If we use medical terms and we use terms that only medical people understand, then it's going to be difficult for your patients to answer those questions and give you all the information you need to assess the cardiovascular system. Additional history for specific populations. When it comes to infants, we want to know what the mother's health was like during pregnancy. If the mother had any disease processes or was on any medications that could have caused heart problems or development problems with the fetus, we want to know that. Can the baby finish a feeding? If the child has to take breaks or the baby has to take breaks during feedings, that might indicate a cardiovascular problem. Is the infant growing as expected? If the infant is not growing as expected, that could also indicate a cardiovascular problem. And is this the infant meeting developmental milestones? There are a lot of developmental milestones that the infant has to meet. So if they're not meeting those, this could indicate a cardiovascular problem. With children, is the child growing as expected? Can the child play without getting fatigued? And then, is there any unexplained joint pain or fever? Any recent viral illnesses? Viral illnesses are known to cause cardiomyopathy in some patients. So if the child does not have that activity level they had prior to the viral illness, then maybe that is indicated a cardiovascular problem. With pregnant women, do they have elevated blood pressure during pregnancy? This could indicate preeclampsia. Is the pregnant woman having fainting or dizzy spells during pregnancy? With older adults, does the older adult have a known heart or lung problem? If so, is the older adult taking medications for this illness? This could also make cardiovascular problems worse. Once the subjective data is obtained, then the nurse can proceed to objective data assessment. In order to do the physical assessment, you need to be prepared, and you also need to prepare your patient. So to evaluate the carotid arteries, the person can be sitting. To assess the jugular veins and precordium, the person should be supine with head and chest slightly elevated. You want to ensure a woman's privacy when you're doing your cardiovascular assessment. You want to gather your equipment and supplies. You want to make sure that your equipment and supplies are in good working order, because you don't want to be going in and out of a room because your equipment's not working. You want to describe the steps of the assessment to the patient so they know what's coming next. The equipment that you'll need will be a stethoscope with a diaphragm and a bell, a small pillow, a light source, a pen light or a movable exam light, a timepiece with a second hand, and 2-centimeter rulers. The first part of your assessment is to assess the general appearance. You want to look at skin color. Is the skin color flushed? Is it a bluish tint? What color is the skin? Is it pale? Is it mottled? Also, moisture. Are they sweating? Are they diaphoretic? You want to assess that. And then you want to assess the precordium. When you're looking at the precordium, do you see any heaves or lifts? And then when you look at the neck veins, are the neck veins distended in a sitting position? Those are all important things to assess when you walk into a patient's room. When you assess the neck vessels, you want to start with the inspection of the jugular veins. There is a nice picture and step-by-step instructions of assessing the jugular veins on page 430 and 431 of your text. When you're assessing the jugular venous pressure, you want to evaluate the jugular venous pressure by watching for the distension of the jugular veins. And you want to do this at different height levels. So you want to do this at the bed elevated 30 degrees, 45 degrees, 60 degrees, and 90 degrees. At each increase in elevation, the client's head should be slightly turned away from the side being evaluated, and you may want to use some light to observe for distensions and protrusion or bulging. When you're assessing the carotid arteries, you want to first listen to the carotid arteries by auscultating with your stethoscope, and you can auscultate with the bell of the stethoscope. You are looking or listening for bruits or any extra sounds, and then you want to, after you auscultate, you want to palpate the carotid arteries. So you only palpate one side at a time, and you palpate just lateral to the larynx. When you're assessing pulses, you want to use the pulse amplitude scale. 0 is absent. That means you cannot feel the pulse at all. 1+ is weak and diminished. It's easy to obliterate that particular pulse. 2+ is normal. It can be obliterated, but you have to use moderate pressure in order to do so. 3+ is bounding, and you are unable to obliterate it. The next step in assessing the cardiovascular system is inspecting and palpating the precordium. When you're inspecting the anterior chest, you're looking for pulsations or heaves or lifts. Heaves and lifts are considered abnormal. Palpation, you want to assess the apical pulse, which is in the mitral area or the 5th intercostal space. The next step in the cardiovascular assessment is auscultation of heart sounds. The cardiac cycle generates sounds that can be heard through the stethoscope over the chest wall. These are the S1 and S2 sounds, or the lub-dub. Occasionally, you can hear extra heart sounds and murmurs. These include S3, S4, and murmurs. Blood circulating through normal cardiac chambers and normal valves should not make any sounds, though. During precordium auscultation, you want to auscultate for S1 and S2 heart sounds. If an abnormal rhythm is detected, auscultate the apical pulse while palpating the radial pulse to assess for pulse rate deficit. You want to also auscultate for extra heart sounds. You want to auscultate for murmurs. It may be necessary for the patient to lie on the left lateral position in order to auscultate heart tones. Here are some tips for precordium auscultation. You want to concentrate and listen selectively to one sound at a time, but consider that at least 2 or perhaps 3 or 4 sounds may be happening in less than 1 second. You cannot process everything at once. So begin with the diaphragm end piece and use the following routine. Note rate, rhythm, and characteristic of sound, loud, soft, the pitch, the timing. Identify S1 and S2. Assess your S1 and S2 separately. Then you want to listen for extra sounds and murmurs. During precordium auscultation, note that sounds radiate with blood flow direction. The valve areas are the aortic area, which is the 2nd right intercostal space, the pulmonic valve area, which is the 2nd left intercostal space, the Erb's point, which is the 3rd intercostal space at the left sternal border, the tricuspid valve area, which is the left lower sternal border, and the mitral valve area, which is the 5th intercostal space around the left midclavicular line. Sounds can be heard throughout the precordium, and then you want to make sure you use the diaphragm for high-pitched sounds and the bell for low-pitched sounds. Murmurs are extra heart sounds caused by turbulent blood flow. They can be innocent, not associated with any cardiovascular problem, or pathological, associated with a cardiovascular problem. So there's a grading scale for murmurs. Grade 1 is faint, it's heard only with great effort. Grade 2 is faint but easily detected. Grade 3 is moderately loud. Grade 4 is very loud, usually associated with a thrill. Grade 5 is extremely loud, and grade 6 is exceptionally loud and can be heard with a stethoscope lifted off the skin. It's important to note the developmental differences in cardiovascular assessment of the different age ranges. For infants, they cannot increase their stroke volume. They can only increase heart rate to compensate for increased workload. Their heart rate is much higher than adults. A normal heart rate for an infant is 100 to 180 beats per minute. That rapid heart rate makes auscultation of the sounds more difficult. And murmurs do not always indicate a cardiovascular problem. Many infants can have an innocent murmur. With children, S3 heart sounds and venous hums may be a normal assessment finding, and then blood pressure should only be checked annually with children. With pregnant women, the pulse rate increases during pregnancy by 10 to 15 beats per minute, and blood pressure decreases from normal pre-pregnancy levels. So if you have a pregnant woman who has increased blood pressure, then that might indicate a problem such as preeclampsia. Also, S3 heart sounds can be normal in some pregnant women. With older adults, it's important to note that there's a gradual rise in systolic blood pressure, and that this is common. Left ventricular wall thickness increases, but the heart size does not increase. The presence of supraventricular or ventricular dysrhythmias can increase with age. And age-related ECG changes occur as a result of changes in the conduction system. And then the incidence of cardiovascular disease increases with age. Risk factors for cardiovascular disease include high blood pressure, high cholesterol, cigarette smoking, diabetes, poor diet and physical activity, overweight and obesity, high C-reactive protein or CRP, high blood glucose, peripheral artery disease, and genetic risk factors. Some nursing diagnoses related to cardiovascular disease include fatigue related to decreased cardiac output, activity intolerance related to compromised oxygen transport secondary to heart failure, acute pain, cardiac, related to an inequality between oxygen supply and demand, anxiety, ineffective tissue perfusion cardiac related to impaired circulation. There are some collaborative problems that might emerge when you are doing your nursing diagnoses, and these are medical problems that can't necessarily be prevented by the nursing interventions that we choose, but they can be monitored and assessed while we are taking care of these patients. So some of the collaborative problems include decreased cardiac output, dysrhythmias, hypertension, congestive heart failure, and angina. I hope you enjoyed this presentation, and please do not hesitate to ask questions when we come to class next week.